Dear viewers, welcome you all to our show Orthopedic Solution Academy Shoulder Clinic. Hope you all are well with your friends, family, and definitely with your patients. Dear viewers, today our topic is shoulder impingement, a very important topic for all of us. And our honorable speaker is Dr. G.M. Jahangir sir, the pioneer shoulder surgeon in Bangladesh. Dear viewers, we have another learned academic expert with us, that is Dr. Rajiv Raman sir. So now I would like to request our honorable speaker, Dr. G.M. Jahangir sir, to join with us.
Thank you, Dr. Tanvir. Dear viewers, Assalamu alaikum. I am Dr.
Thank you.
G.M. Jahan, working in NITU Dhaka as associate professor. Today, I am going to discuss about the shoulder impingement syndrome, or it may be called painful arch syndrome. There are two types of shoulder impingement syndrome: the external or subacromial impingement or internal impingement. Basically, today I will discuss the external impingement or subacromial impingement. First, we know what is impingement. Compression and mechanical irritation of supraspinal tendon as it passes beneath the anterior third of the acromioclavicular joint and coracoacromial ligament during elevation of the arm or overhead or lift of the arm side away from the body. And this is called impingement. That means in this situation, supraspinatus muscle is impinged by the coracoacromial arch. Usually, patients with impingement syndrome present to us like pain when extending arm to reach something, and pain when lifting the arm from a height or moving the arm above the head, and pain and tenderness when the arm is at rest position, and experiencing pain when reaching toward the back. Usually, patient come to us mostly with he cannot access the back of his chest, he cannot pick up his back pocket and manuback parts, etc. This is the common feature for the uh, patient present to us with impingement syndrome. And more, pain that radiates from the shoulder front and reaches to the arm side, and difficulty lying on the sleeping on the affected side of the body. Generally, patient complain there is weakness or stiffness of the shoulder joint. These are the common finding in case of shoulder impingement syndrome. Key points. Usually we source the basic key points of shoulder impingement syndrome or painful arch syndrome. Usually pain. What type of pain and when it's occur more? That is nocturnal pain. It is more severe in at night, and pain aggravates during the overhead activity, and patient usually unable to sleep on involved side and to reach the behind the back. And this painful syndrome usually occur during the range of painful arc like 70 degree to 120 degree of range of motion, and we can detect easily this painful symptom by painful arc syndrome or impingement by EG2 test, that is near test and Hawkins Kinney test. And mechanism of pain, that means how pain occur in the impingement syndrome. That is repetitive injury in the rotator cuff tendon causes inflammation in the tendon and muscle, making the movements full of pain. And locating the exact site of lesion causing the painful arc is important to give the appropriate treatment. That means what are the site of inciting agent or what the site of impingement or what are the site of disease, we can easily detect and can treat accordingly. And what happened in shoulder impingement syndrome or painful arc syndrome? This is very important. So if we know this, we can know the pathology and treat the patient. The tendons, especially rotator cuff, and ligaments, especially coracoacromial ligament, coracohumeral ligament, are swollen, thickened, and calcified or torn. All these causes impingement syndrome mostly. Suppressed tendinopathy is also very commonly a cause of shoulder impingement syndrome. So ligaments, rotator cuff tendon, and tendinopathy, all this leads to shoulder impingement syndrome. Recurring stress and overuse of the supraspinal tendon can cause its damage in middle-aged people. And the wear and tear of muscle can also be an age-related injury, which causes the shoulder impingement syndrome. And also patient present to us with shoulder impingement syndrome and how they occur, especially when fluid field bursa decreases, the possible friction between the anterior edge of the acromion and the rotator cuff increases tear. And if fluid of bursa decreases or damage to the subacromial bursa occurs, the area of tendon can become inflamed. Bone spur, naturally non-flat bone of the acromion, will result in a painful arc syndrome. If we see the painful arc which has occurred between the 16 to 120-degree range of motion, in this situation, the anterior part of the supraspinatus muscle come to the contact with the anterior end of the acromion and coracoacromion ligament as well as coracoid process. So all these are the key points where the impingement occur of the supraspinatus muscles. There are some points where impingement occur, mostly anterior acromial impingement and posterior superior impingement or internal impingement between the infraspinatus tendon and the posterior superior glenoid labrum. It occurs when shoulder in abduction, external rotation position. Basically, this is position is internal impingement, but today we concern mostly with external impingement, that means subacromial impingement. Subcoracoid impingement between coracoid and lesser tuberosity, and suprascapular nerve impingement, entrapment at the spinoglenoid notch. It is also part of the internal impingement. And there are some factor which causes external impingement, that means subacromial impingement. Both some are bony factor and some are soft tissue factor. In case of bony factor, it comes past the shape of the acromion. In case of flat acromion, we can see here, and type 2 acromion, that is curved acromion, type 3 acromion, that is hook variety acromion, and type 4 acromion, which is convex variety acromion. These are the anatomical variant of the acromion which causes the impingement, especially type 2, 3, and 4. This is the anatomic factor which causes impingement. And this abnormal acromion we can see by MRI easily by the sagittal section of MRI. In this is a flat variety, this is a curved variety, this is a hook variety of acromion, and it is convex variety of acromion. Can see in the sagittal view of MRI. And also there are some bony factor we are seeing regularly during the plain X-ray, like this is subacromion spur. This is causes impingement when raises the arm at the level of shoulder or above the head. This spur impedes the supraspinatus muscle against the humeral head. And this is a hook variety of acromion, which is the dangerous type of acromion, which is cause impingement, ultimately lead to tear of the supraspinatus muscle in time being. And another impingement also, there is subacromion spur, which is cause impingement, and another rare variety of impingement like os acromion. This is acromion and this is the os acromion. It looks like is a fracture, but this is a part of acromion which is unfused acromion. Tip of the acromion unfused. It is called os acromion. And sometimes it hangs or sometimes it protruded downwards. And when arm raises, it causes impingement of the supraspinatus muscle, ultimately lead to tear. And subacromion is other cause bony factor which causes impingement like AC joint osteophyte. This is osteophyte of AC joint which causes impingement of the supraspinatus muscle. As well, you can say this is the calcific supraspinatus tendinitis. And calcification, always we can see this calcification within the tendon. It is like globular and radiolucent in transparency. It is always calcific tendinitis causes impingement. And other variety you can see here, that is subacromion calcified bursa. That is long. And this type of calcification seen, it is called calcific bursitis. It is also causes the impingement. And other this variety within the tendon, that means within the tendon of the supraspinatus, it is called calcific tendinitis. And this is causes a impingement of the supraspinatus muscle. This is supraspinal tendinitis, calcific tendinitis. This is calcific subacromion bursitis. And there are other soft tissue factors which causes impingement, like subacromion bursitis. This is subacromion bursitis, supraspinatus tendinitis, thickened or calcified coracoacromion ligament, sometimes bursal-sided traumatic or degenerative fascial tear of the supraspinatus tendon or muscle. All are soft tissue, causes subacromion or external impingement of the shoulder joint within the range of 60 to 120-degree range of motion. And some test, we can easily detect the impingement by test. First test come to us is a near test. It is the easy test when to see the near test. We can do see the video for a detection of impingement by near test. Sorry. You can see
near
this video.
Test, it is a passive test. When I conducted the test, just I established the scapula and upper limb is fully pronated and forcefully elevated the arm. If there is some acromion impingement, patient will complain pain in the shoulder region. And if there is pain complaint within the anterior shoulder, it may be external impingement, or if you complain of posterior pain, then it is the internal impingement.
Then come to the next test, that is Hawkins-Kennedy test.
For assessing the Hawkins-Kennedy test, stabilize the scapula with one hand and with other hand 90-degree flexion of the shoulder and 90-degree flexion of the elbow, then suddenly internally rotation. If there is subacromion impingement, there is pain within the shoulder. That means that is supraspinatus muscle come in contact with the anterior part of the acromion and coracoacromion ligament.
And this painful condition leads to impingement of the supraspinatus, which is a test of to detect the supraspinatus impingement.
In case of Vulcan test, shoulder are elevated 90 degree at the scapular plane and thumb is directed towards the ceiling and surgeon pressure the both arms downwards and patient will resist. If there is subacromial impingement, that means rotator cuff injury or weak, then patient will complain at the affected shoulder.
If rotator cuff, that means supraspinatus, is not impinged, there is no pain in the shoulder.
In case of Vulcan,
for empty test,
shoulder are elevated 90 degree at the scapular plane. Thumb are directed downwards towards the floor. Surgeon will press downward and patient will resist. If there is subacromial impingement, that means supraspinatus muscle come in contact with the anterior acromion and coracoacromial ligament. It will impinge and causes pain.
And also, when there is supraspinatus weakness or tear, in this position, patient will not resist the downward pressure by the examiners and complain pain or suddenly fall down the arm. So it is a empty can test. By this test, and easily can detect the impingement or of supraspinatus or tear of the supraspinatus muscle.
What?
So in this slide, we can show a video by which we show that there is impingement, subacromial impingement. That means there is bursitis as well as subacromial spur and incision osteoarthritis. In this arthroscopic procedure, we can easily decompresses the subacromial bursa, and with the radio frequency ablation, we can ablate the bursal tissue. You can see here, and unwanted tissue and fraying of the rotator cuff. And with the help of bar, we can decompress the spur. Decompress the spur gradually, subacromial spur, and keep the shape of a slope variety of acromion, which causes impingement. Now you can see there is all the spur tissue are removed and the acromion under surface take a normal size. So muscle will not impinge, compress, or muscle will free. And now there is a full range of motion and there is relief of pain. Sometimes when this spur causes injury to the supraspinatus muscle, either partial or complete. So before any rotator cuff repair, we always decompress the subacromial space and acromioplasty, and then repair of the torn rotator cuff. So at the end of my slide, we may conclude that history, physical examination, and relevant X-ray, CT scan, and MRI investigation sought the cause of impingement or painful arch syndrome. Medical treatment and physical therapy play a vital role for improvement of the condition. That means medical role, painkiller, analgesic, physiotherapy, electromagnetic physiotherapy, it should be continue up to 3 months. If there is no improvement or there is any mechanical obstruction, then arthroscopic procedure is the treatment of choice for the resistant and mechanical block induced impingement or painful arch syndrome. Thank you. Thank you for watching this program.
Thank you very much, sir, for your highly informative presentation. Sir, I have a questions that sometimes we do scapular Y view to see the acromion properly. Do you do this scapular Y view invariably in your country in Bangladesh?
Yes, we can to see the acromion easily we can detect the scapular Y view. This view can easily detect to see the posteriorly acromion and anteriorly coracoid. But it is not possible until unless as orthopedic surgeon directed to the radiologist or radio technician to do the x-ray in this view. So when we advise to do and train the technician to do the x-ray in the view, we can easily detect the types of acromion, and as well as in MRI, we can easily detect the variety of acromion on MRI. On sagittal view, we can easily detect.
So, is there any necessity of doing a CT scan in this case?
Yes, CT scan also very important to see the acromion variety of acromion and other abnormality like AC joint, osteoarthritis, and as well as when we do like Zanka view of the AC joint. Without Janka view of AC joint X-ray film, we cannot detect the pathology of AC joint. Sometimes some fracture, even type 4 dislocation of AC joint, we cannot detect normal X-ray. To see it, we can do the Janka view. So CT scan by special view X-ray like Janka view for the important to detect the AC joint and other part of the bony contour of the shoulder joint.
Thank you, sir, for your nice answer, sir. Sometimes we face that the patient is not economically solvent, so that he or she can't do the MRI or CT scan. In that case, is there any role to do the ultrasonogram, musculoskeletal ultrasonogram of shoulder joint to diagnose the shoulder impingement syndrome?
Yes, if musculoskeletal, especially who are musculoskeletal specialist sonologist, they can easily detect the tendinitis, bursitis, especially subacromion, subdeltoid bursa, as well as detect the tendinopathy. Even sometimes detect there also some calcification and degenerative tear of the, I mean, external impingement factor. They can detect some calcific tendinitis they detect, but internal impingement like labral injury, that some etc cannot detect.
Sir, my last question is, how can we diagnose that is it a rotator cuff tear? It is a without cuff tear shoulder impingement, or is it a tendinitis? Among these three diseases, how can we differentiate easily, both clinically and by both radiologically?
Yes, it is a very important and authentic question. A patient can itself move his shoulder with pain but and difficulty. But it is all movement is possible with pain and difficulty. And then in this situation, it is called impingement. When patient is not possible to do the movement, but both examiner and patient itself cannot do the movement, then it is stiff shoulder or adhesive capsulitis or frozen shoulder. But when there is a tear of rotator cuff, patient cannot move the shoulder, but examiner can move the whole range of motion when there is no stiffness. So we can easily detect in case of impingement, both examiner and patient can move the shoulder total range of motion with pain or with difficulty. But in case of frozen shoulder or stiff shoulder, both patient and examiner cannot move the shoulder joint. When there is tear, patient cannot move, but examiner can move. But certain tests like supraspinatus test, infraspinatus test, this test, active test, patient cannot do it. And if patient examiner himself raise the arm of the patient, but he cannot hold it there, it suddenly fall. These are the so in this situation it indicates there is rotator cuff tear. So these are the easily detect by examining both patient as well as clinician.
Thank you, sir. Thank you very much for elaborating these things very nicely. Dr. Parvez Hassan, sir, has joined with us, though it's too late. So thank you very much for joining with us. Sir, Professor G.M. Jangir, sir, already told us about the shoulder impingement. Do you have any queries or do you want to share anything regarding the shoulder impingement with us, sir, please? First, you have to unmute yourself, sir.
Shoulder impingement is a very common p- problem of the patient with shoulder problem. Especially the old age, especially they comes initially with uh, difficulty in elevating his arm, and it starts with pain, and initially they could move a little, but if you want to move freely or independently, they found it difficult. This is probably the initial stage of rotator cuff tear. So I want to know the initial treatment of the shoulder impingement. Is it only mobilizing the shoulder joint, or other thing could apply here?
Who will? Me? To me? You have question to me?
Yes, sir.
Yes, GM
Yes.
Jangir.
Yes. Basically, shoulder impingement must be diagnosed by first, what are the causes of shoulder pain or limitation of the range of movement? When there is bursitis, subarachnoid bursitis, or tendinitis, or any other soft tissue factor, all these lead to pain and some movement limitation. But movement is full with difficulty. But when there is other cause of like adhesive capsulitis, in this situation, both patient and examiner do not move the shoulder. So you can understand what are the stages. Some are aggravating factor like diabetes, endocrine disease, other disease, heart disease. You should to think if this thing is present, there is chance of development of adhesive capsulitis. Although idiopathic capsulitis is more.
Now, my question was what is initial treatment? Say he had some form of impingement. He had developed some form of impingement. He developed pain and mild restriction of the range of movement. Initial stage, do we apply only physiotherapy or other? It may turn into a second stage. I want to say that what should be the initial stage treatment of the shoulder impingement?
Yes, it is very good question. My first approach is what are the cause of impingement? If it is diagnosed impingement, what are the cause of impingement? If it is either mechanical, that means bony factor, or it is soft tissue factor.
Yes.
If it is soft tissue factor like bursitis, tendinitis, then we go for conservative treatment like regular physiotherapy, patient itself, and relief of analgesic. If you prescribe some sort of physiotherapy like ultrasound or short wave, they will relieve pain. And at the same time, you can start strengthening muscle strengthening exercise, range of motion exercise, and simultaneously with the electromagnetic physiotherapy and analgesic muscle relaxation, so on.
Okay. Then when we, in which stage we will go for surgery in shoulder impingement?
Yes.
When we'll go
if there is
decide
some
that we need surgery? Yes.
if there is some mechanical factor like recurrent calcific tendinitis like subacromial spur, and that is AC joint osteoarthritis, and if there is long time bursitis, calcific tendinitis, they will relieve some pain for a short period of time, but long standing they will recur. In this situation, I go advise for arthroscopic surgery.
What arthroscopic surgery used to do
Like
in shoulder impingement?
it is simple, just subacromial decompression with or without acromioplasty. If there is osteophyte, you remove the subacromial spur, you remove the AC joint osteophyte, and remove the calcific bursitis, remove the calcific tendinitis. This type of subacromial, that means subacromial decompression as well as acromioplasty if necessary.
Is there any time when you go for resection of the clavicular end?
Sorry?
When you go for resection of clavicular end?
Yes. Clavicular end is a AC joint resection.
Yes.
When there is severe osteoarthritis of AC joint and it causes impingement of the supraspinatus muscle, then we resect the AC joint resection.
Yes.
It is a part of treatment of the impingement syndrome.
Okay.
Thank you very much, sir, for a nice discussion. Sir, my one last question is, as because of we use invariably steroid in shoulder impingement, as because of the lack of diagnosis. Sometimes, if there is no rotator cuff tear, and if there is no mechanical factor is there present, only soft tissue factor is present there, such as the bursitis or tendinitis or subacromial bursitis, can we give intra-articular and interlesional or subacromial space steroid injection in that case? We're using this steroid invariably, and we're getting a good result. And I want to know what is your opinion regarding this matter, sir.
Now, yes, it is a part of conservative treatment. If you think there is subacromial impingement and this impingement is due to the bursitis, tendinitis, like subacromial bursitis, subacromial tendinitis, or sometimes AC joint arthritis, or sometimes subcoracoid bursitis. In this situation, you can prescribe 2 to 3 dose of injection and yearly. It will relieve pain. Yes, it is a
Sir,
part of.
where will be the site of the injection? Sometimes we go to the shoulder joint, and sometimes we give in sub acromial space also. Can we do it combinedly in a same sitting?
Repeat question.
Sometimes we give intra-articular injection, we give it in the shoulder joint, and sometimes we give it in subacromial space also.
Yes.
Can we do it combinedly, such as in intra-articular 2 ml or in subacromial space 1 ml steroid injections?
No, no. This is very important. Diagnosis. What type of impingement it is? Either it is internal impingement or it is subacromial, that means external impingement. 80 to 90% impingement, it is subacromial impingement, like bursitis, tendinitis. So I think if it is subacromial impingement, there is no role of interarticular injection. You just give subacromial. Anyway, it may go through the posterior approach or through the lateral approach, subacromial space. So, and to do the interarticular, it is difficult to find the joint space. You only capsulitis, when we think frozen shoulder or capsulitis, whatever the cause, then we go for intraarticular. Otherwise, no need. Only impingement, you can think it is a subacromial impingement, you go subacromially. Internal impingement mostly due to the posterior labral tear or anterior labral tear or intra-articular rotator cuff tear. These are the causes of internal impingement. You should diagnose it either MRI. So most of our patients come to us with subacromial impingement. So do not go for interarticular, only subacromial.
I, can I say some
Yes,
words
yes, yes,
regarding
yes.
the
Yes, sir.
intra-articular injection? The problem of us is improper diagnosis. Where if we could diagnose that he had some subacromial bursitis or any inflammatory condition, that will intra-articular injection will do better.
Yes.
But before giving any intra-articular injection, if you could diagnose by MRI and clinically that this is happened, so I could give intra-articular injection, the result is better. But before going for any diagnosis, and if it is some sort of restriction of movement, if I apply intra-articular injection, what I have seen not satisfactory result.
Yes, sir.
Okay, especially a lot of patient comes with that they have not good result of regarding movement mobilization, especially what I usually practice, because shoulder problem is very common. I usually practice sometimes I give intra-articular injection to relieving pain, and for patient's physiotherapy it will give some sort of physiotherapy. But before giving the intra-articular injection for relieving pain, I want to do diagnose what happened. Is it rotator cuff tear? Is it true adhesive capsulitis or stiff joint or labral tear? That is it. So those person who know the diagnosis and those person who know the what is going to relieve the intra-articular injection, then I think that is proper way to give intra-articular injection. Because diabetes patient, intra-articular injection does not relieve pain or anything. This is my
Thank you,
experience.
sir. Thank you. Thank you very much, sir. And thank you, Parvez Hassan, sir. Thank you, GM Jagir, sir, for a lively discussion. And I would like to thank Raj Tv for helping us to arranging this type of academic program, and definitely Malaysia ENT Specialized Hospital. I'm Dr. Mohammad Tanvir Ashraf saying bye bye today to you. Hope we will connect with you in the coming Friday with another shoulder problem. Till then, I would like to say bye bye to all of you. Bye bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.